This recorded lecture will be going over Chapter 17, the cardiovascular system, in the MedSurg textbook. The heart wall consists of 3 layers. Most of this first part will be an overview from structure and function, so I am going to skim through what I feel like are the most important points to recall from our previous studies. The pericardium is a double-layered sac. The double layer helps provide a barrier to infection, prevents displacement of the heart, and contains pain and other receptors that will elicit reflex changes in heart rate and blood pressure. On page 377, we can see direction of blood flow through the heart. This is a great picture. This is one of those pictures I would maybe even make a copy of this page of your textbook, cut that out, and just put it right into your notes. Really good color coordinating for the blood flow through the heart. The point of maximal impulse, or PMI, can normally be felt between the 5th and 6th ribs on a line dividing the left clavicle in half. Listen to the apical heart rate at this location. The SA node, or sinoatrial node, is located in the right atrium. It is called the pacemaker of the heart because it normally initiates the electrical impulses. The cardiac cycle consists of contraction of the muscle, which is systole, and relaxation of the muscle, diastole. The heart pumps out about 5 liters of blood every minute, and that is your cardiac output. The amount of cardiac output depends on the heart rate, the amount of blood returning back to the heart, which is your venous return, or also known as preload, the strength of the contraction, and then the resistance to the ejection of the blood. This is also known as afterload. Stroke volume is equivalent to the amount of blood ejected by a ventricle during one contraction. Cardiac output equals stroke volume multiplied by the heart rate. The ejection fraction is the percentage of blood that is ejected from the left ventricle during systole. A normal ejection fraction, also known as an EF, should be between 50 and 70%. As the ejection fraction decreases with heart failure, tissue perfusion will diminish. We can see this picture on page 378 showing a view of the coronary arterial system. And this picture is on page 378 as well, showing the cardiac conduction electrical system. Arteries carry oxygenated blood away from the heart, and veins carry oxygen-depleted blood back to the heart to be reoxygenated by the lungs. Small veins or venules and small arteries, known as arterioles, are connected by the capillaries. It is within the capillaries that oxygen can be transported to cells and waste products are removed from them. Veins are thinner and less rigid than arteries, and therefore they can hold more blood. Skeletal muscle contraction, respiratory movements that change pressures in the chest, and constriction of the veins will propel blood back to the heart. For blood to circulate, the arteries must be unobstructed, and they must be able to dilate and constrict as necessary in order to regulate the flow of blood. Arterial blood pressure is the force that the blood exerts against the walls of the aorta and its branches. Diastolic pressure is the pressure when the ventricles are in the relaxation phase, also known as diastole. This occurs just before the next contraction of the ventricles. In this state, the heart is relaxed. The ventricles are relaxed. The difference between the systolic blood pressure and the diastolic blood pressure is known as pulse pressure. If the diameter of blood vessels becomes smaller due to atherosclerosis, blood pressure will be increased due to the effort of forcing that blood through a smaller opening. Atherosclerosis is a condition in which fibrous plaque with fatty deposits forms in the anterior layers of the arteries, resulting in narrowing. If blood volume decreases, the kidneys will secrete the enzyme renin in the blood. That will initiate the renin-angiotensin system, or our RAS system. Blood flow is affected by the amount of resistance in the vessels and the viscosity of the blood. When the vessel diameter increases, resistance falls and blood pressure will decrease. When vessel diameter decreases, resistance will rise and blood pressure increases. blood viscosity is affected by the hydration status of the body. The cardiac valves become thickened with age, particularly the mitral and aortic valves. These can be subject to higher pressures. A systolic murmur is common in patients older than the age of 80. Murmurs are common due to insufficient valves. The SA node loses about 40% of its pacemaker cells over time. This will predispose the older adult to cardiac dysrhythmias or abnormal rhythms. It can also lead to SA node failure. Platelet aggregation and increased coagulation potential will lead to a greater incidence of thrombus formation, DVT, and thrombophlebitis in the older adult. Cardiovascular disease is responsible for the largest portion of Medicare funds spent every year. When a disorder of the cardiovascular system occurs, homeostasis is upset. Many of the disorders that affect the cardiovascular system can be prevented or controlled. Heart disease incidence in women is almost equal to that in men. More women than men die each year of heart disease. The risk factors are similar to those for men, including high cholesterol, high blood pressure, and obesity. But other factors will play a bigger role for women, including diabetes, metabolic syndrome, smoking, and mental stress. On page 381, see the green health promotion box regarding preventing cardiovascular disease in women. It is very, very important for women to increase stress reduction techniques within their daily lifestyle because increased stress is a serious risk factor for cardiovascular disease in women. Causes of cardiovascular disorders can be congenital or acquired. Narrowing of the aorta, also known as coarctation, holes in the septum, or abnormal formation of a cardiac valve can occur congenitally. Acquired deficits would include narrowing or hardening of the blood vessels due to arteriosclerosis or atherosclerosis, as well as aneurysms of large vessels. Alteration of the myocardial muscle tissue by extra growth with thickening or fibrosis can also occur as a result of systemic hypertension, pulmonary hypertension, or valve problems. Lack of adequate blood supply, known as ischemia or infarct, can occur due to coronary artery disease. When the heart is not able to pump enough blood to meet the body's needs for oxygen and nutrients, heart failure is diagnosed. Disturbances in any part of the heart's conduction system can result in an increase in heart rate, a slowing of the heart rate, and disturbances in the rhythm of the heartbeat. Infection and inflammation can also take their toll on the structure and function of the heart. Endocarditis is inflammation within the lining of the valves of the heart, and pericarditis is inflammation of the sac surrounding the heart. These can both occur as primary diseases, but they are more often secondary to an infection and inflammation somewhere else within the body. Substances in the blood, such as excess carbon dioxide and certain drugs, can affect the rate and rhythm of the heart through their effect on the autonomic nervous system. Hypertension causes a mechanical injury by applying increased pressure continuously on the arterial walls. For each increment of 20/10 millimeters of mercury above a pressure of 115/75, the risk of cardiovascular disease doubles. Chemical toxins such as nicotine from tobacco and their toxins can cause renal failure as well as injury to the arterial walls. Substance abuse with alcohol, stimulants, and recreational drugs is damaging to the cardiovascular system. Physiologic disorders, including diabetes mellitus and metabolic syndrome, will directly cause physical changes in the vessel walls, leading to more rapid arterial sclerosis, an increased rate of atherosclerosis, and an earlier onset of hypertension. Obesity, a sedentary lifestyle, and stress are all directly related to the increased incidence of atherosclerosis and hypertension. Hypertension in some cases cannot be prevented, but it can be managed with diligent therapy and cooperation from the patient. Cardiovascular disease, as the underlying cause of death, accounts for 1 in every 3 deaths within the United States, totaling 836,546 deaths annually. Knowing the warning signs of a heart attack is very important. We can find a table on page 382 going over these signs, including chest discomfort, pain or discomfort in another area of the upper body, including the arms, shoulder, back, neck, jaw, or even the top of the stomach. Shortness of breath, breaking out in a cold sweat, a feeling of impending doom or unusual fatigue, and of course, chest pain. Call 911 or an emergency number immediately. Get help. Take an aspirin, preferably a full dose 325 milligram aspirin. Non-modifiable risk factors are those that cannot be prevented by an individual. However, control of diseases like hypertension and diabetes and the reduction of high cholesterol are possible. Because hypertension and diabetes are factors in the development of atherosclerosis, controlling them can help prevent the early onset of heart disease. Metabolic syndrome is a strong indicator of cardiovascular risk, and it is diagnosed when one or more of the three components listed in box 17.1 on page 383 are present. Modifiable risk factors are the major focus of education to prevent heart disease. Cocaine causes vasoconstriction and is believed to speed up the atherosclerotic process. Research is finding that the ingestion of alcohol and cocaine will greatly increase the chance of cardiac death. Methamphetamine use will increase heart rate, cause vasoconstriction that can lead to hypertension, and speed up electrical conduction, potentially causing dysrhythmias and myocardial infarction. The guidelines for management of hypertension recommend implementing antihypertensive medications for patients 60 years or older with a systolic blood pressure at or above 130 or a diastolic blood pressure above 80. On page 383, we can see table 17.1 listing the risk factors for cardiovascular disease. Note the modifiable risk factors, as well as the means of modification. Especially take a look at diabetes and note that we can maintain good glycemic control by keeping the blood glucose within normal limits, or less than 100. Stretch. Nurses can play an important role in teaching others about hypertension, support patient efforts to prevent the disease and its long-term consequences, as well as contribute to reducing the incidence of harmful effects of hypertension by participating in community screening programs and education. On page 383 within box 17.1, we can also see some metabolic syndrome components. Continuous monitoring of cardiac rate and rhythm is done by telemetry. Cardiac monitors can detect specific dysrhythmias and automatically store the wave pattern and then alert you to the abnormality that had caused the alarm. Diagnosing a vascular problem will begin with a history and physical examination, including a variety of tests looking for risk factors for vascular disorders. A complete blood cell count, urinalysis, blood lipid and cholesterol assessment, an LDL lipoprotein, as well as a sequential multiplier analyzer panel that screens lipid and kidney function, liver and kidney function, electrolytes, and blood glucose should be ordered. Doppler flow studies can be performed to detect a venous thrombus when one is suspected and to assess the patency of the carotid arteries. Angiography may be performed to determine areas of narrowing in arteries or to detect a blockage. An echocardiogram can be performed to assess wall motion of the heart, valve function, and ejection fraction. The ankle brachial index, or ABI, is an inexpensive, non-invasive bedside screening test to evaluate for arterial status in the lower extremities. An ABI of 1 or more would be considered normal. An abnormal ABI, or less than 0.9, indicates arterial disease, and this can confirm a vascular cause for ischemic pain in the legs at rest, as well as intermittent claudication. This is cramping pain in the muscles brought on by exercise and then relieved by rest. Intermittent claudication pain is most common in the calves of the legs, but it can also affect the muscles in the thighs and the buttocks. It is important to determine whether your patient has any risk factors for cardiovascular disease. Information concerning the patient's actual eating habits, including snacking on junk food or daily consumption of several drinks containing caffeine, is more likely to be obtained during nursing care activities rather than the initial assessment. An understanding of the patient's perception of their condition and their overall health is necessary to plan appropriate teaching. Patients sometimes do not consider over-the-counter items as medications, and they will not report their use. A careful, specific diet history must be gathered. Fast food intake is significant because this food is often high in fat and sodium. Excessive alcohol intake is another factor in the development of hypertension and cardiomyopathy. Significant findings during the physical assessment would include abnormal or extra heart sounds, crackles in the lungs, or pink frothy sputum that could indicate pulmonary edema. Chest pain, if present, should be further assessed using the PQRST memory device. If you need a refresher on this, you can see it within Table 17.3 on page 393. A pulse deficit is the difference between the apical and the radial pulse rate when they are counted at the same time. An apical pulse rate should be taken for all patients upon admission. Heart sounds are auscultated at least every 8 hours on all patients with a known dysrhythmia or potential for dysrhythmia, a valve problem, or heart failure. The diaphragm of the stethoscope is placed over the bare skin at the mitral area to listen to the apical pulse. S1 is lub and S2, dub, should be distinguished. The bell of the stethoscope should be used to listen for heart murmurs. It can be placed lightly on the skin for sounds to be heard. Murmurs typically have a swooshing sound from turbulent blood flow. Murmurs are commonly the result of damaged valves, causing abnormal blood flow within the heart. Because heart sounds typically are very soft, ask the patient to refrain from talking and turn off the television or any other sources of extra sound while you're listening. Check the arterial pulses and determine the pulse rate, rhythm, and character or force of the pulse. The apical pulse should be counted for a full minute. The carotid, femoral, popliteal, and pedal pulses should also be palpated and compared bilaterally, noting quality and character. The quality of pulses is graded as to their intensity. The character of the pulse is its regularity. On page 394, see box 17.2, Scale for Grading Pulse Quality. Notice how a +3 score is equivalent to a normal pulse volume. If pulsations are weak or undetectable, use a Doppler device to check them. Examine the abdomen with the patient lying supine to observe for a visual abdominal pulsation from the aorta. This would indicate the presence of an aneurysm. If a pulsation is seen, do not palpate the abdomen. A whooshing or purring sound, also known as a bruit, is made when blood passes through a turbulent area of an artery, possibly caused by partial obstruction or when the blood is flowing too rapidly. To detect bruits, listen with the bell of the stethoscope applied lightly over the skin of the carotid arteries, the abdominal aorta, and femoral arteries. Blood pressure should be carefully measured with the correct cuff size. If the cuff is too narrow, the blood pressure will be falsely elevated. The inflatable portion of the cuff should be centered over the brachial artery, and its length should cover at least 80% of the extremity's circumference when positioned correctly. Blood pressure should be assessed on both arms. Orthostatic or postural hypotension can occur when the blood pressure drops as a person stands. Syncope is another word for fainting. A decrease of 20 millimeters of mercury in the systolic pressure or a drop of 10 millimeters of mercury in the diastolic pressure within 3 minutes of standing up is considered orthostatic hypotension. In cardiovascular disease, tissues deprived of normal amounts of arterial blood will appear pale and mottled. In dark-skinned people, the mucous membranes will be rosy and pink if the oxygenation is adequate. The return of color to the lowered feet is delayed in arterial insufficiency. If there is severe peripheral arterial disease, the dangling feet will take on a dusky red color. This is known as rubor. The skin can also be shiny and taut. When a patient experiences persistent coldness of an extremity in a warm environment, you should suspect peripheral arterial disease. Skin that is chronically malnourished due to decreased blood supply will have a characteristic appearance. The skin will appear smooth, shiny, and thin, and there will be little to no hair on its surface. The nails will be thick and yellow. Edema is either present, absent, pitting, or non-pitting. Pitting means that a fingertip pressed into the area for 5 seconds will leave an indentation. The capillary refill test has traditionally been used to check peripheral circulation. Normally, the color should return immediately. In less than 2 seconds is considered normal. A goal of community nursing is the promotion of healthful living to prevent cardiovascular disease. When planning care for cardiovascular patients, it is important to schedule nursing activities to conserve the strength of the patient and prevent excessive fatigue. Patients undergoing telemetry monitoring should not be disconnected from their monitor for any extended time. Reconnect the leads immediately afterwards. When a patient has a history of thrombosis, you should plan measures to prevent recurrence regardless of the patient problem that is currently the focus of their treatment. A large part of what you do for a patient with cardiovascular disorder is monitoring their condition and determining whether the treatment you're giving is effective. Cardiovascular patients will often be treated by the physical therapist, dietitian, and respiratory therapist, as well as the primary healthcare provider, cardiovascular specialist, and a nurse. It's important to consult with other healthcare professionals involved in the patient's care. When evaluating, check laboratory values for therapeutic drug levels before giving doses of medication, and always note the latest blood levels of electrolytes. Ask yourself if the patient is showing signs indicating that the medicine you're giving is effective. It is important to look at serial blood pressure readings to evaluate the effectiveness of treatment and of nursing interventions. Pressures that are consistently higher than normal between medication doses would indicate a need to either change the dosage or the medication. Carefully evaluating pulses and comparing them bilaterally are important parts of nursing care for patients with problems of the cardiovascular system. It is important to determine whether skin color and temperature have changed since the last assessment. Monitor ulcerated areas closely and measure as well as photograph per policy the areas to determine whether healing is occurring. When the coronary arteries fail to supply adequate oxygen to the cells of the heart muscle, the heart is unable to perform as it should, especially when any extra demands are placed on it. The result of this is general hypoxia of the tissues throughout the body, and this results in fatigue as well as dyspnea on exertion. The patient should be cautioned against any strenuous activity, and response to activity should be monitored via telemetry to watch for any dysrhythmias or excessive heart rate changes. Criteria used to determine whether a cardiac patient is tolerating their activity would include the following. The heart rate should not rise more than 20 beats per minute over baseline. Systolic blood pressure should not drop. There is no complaint of chest pain, dyspnea, or severe fatigue. There is no abnormal heart rate or rhythm. Edema is an accumulation of fluid in the interstitial fluid compartment. Edema is a problem in heart disease when blood flow into or out of the heart is inhibited, This will cause a backup of body fluids in the vascular space, which in turn causes that fluid to relocate to other tissues. Continually assess the fluid balance of a patient with cardiac disease by looking for signs of abnormal collection of fluid in the body tissues. Daily weight change is considered the best indicator of fluid buildup. Observe for progressive signs of shortness of breath and auscultate lung fields each shift to detect crackles, which is a sign of beginning pulmonary congestion. On page 401, see the purple box of clinical cues. A weight gain of 2 to 3 pounds or more in 2 or 3 days or less would indicate fluid retention. Nursing responsibilities include recording of the patient's daily weights before breakfast, supervising fluid restriction, accurately measuring intake and output, and assessing for any other signs of fluid deficit and fluid overload. Chest pain can be a symptom of a life-threatening heart event. Palpitations can be another symptom. Stable angina pain can be treated with nitroglycerin, oral nitrates, oxygen, reassurance, and careful monitoring for relief. If the pain is not relieved, emergency care should be implemented. The goals of treatment are to restore the oxygen supply to the heart and relieve the symptoms. Morphine, nitroglycerin, and oxygen are given as well as low-dose aspirin, not to decrease the pain, but to decrease the stickiness of platelets and prevent any further clot occlusion of the coronary arteries. In peripheral vascular disease, blood flow can be sluggish or altered by the constriction of the vessels. The smooth muscles of the arterial walls will respond to temperature by constricting in the presence of cold and extreme heat, and then relaxing in the presence of warmth. Therefore, the nursing care plan should include providing a warm environment for the patient, covering the hospitalized patient with warm blankets or dressing them in warm clothing, and instructing the patient to avoid extremes of cold and heat. Constricting clothing, elastic materials in underclothing, tight socks, and other form-fitting clothing should be avoided. Frequent position changes are essential, and positions should be changed every 2 hours. Patients with poor venous circulation can benefit from periodic elevation of the lower extremities above the level of the heart to facilitate venous return of blood to the heart. To provide this kind of support, the healthcare provider can prescribe an elastic bandage or fitted elastic stockings. The patient should have 2 pairs of elastic hose and should wash the hose after each day's wearing. Elastic hose should be replaced every 6 months because they will lose their elasticity. When stockings are removed, the heel should be checked for pressure areas. Elastic stockings should not be used for patients with arterial disorders. Exercise is especially beneficial to patients with decreased blood flow. Walking is the ideal exercise for ambulatory patients. Bedridden patients will need range of motion exercises and other kinds of muscular movements. Tissues that have a diminished blood supply are subject to severe and permanent damage from the slightest injury because the normal processes of healing and repair are impaired. Arterial and venous stasis will often lead to chronic leg ulcers. Prevention of leg ulcers would include wearing elastic bandages or support hose, proper positioning and exercise, preventing injury to the feet and legs, and avoiding extremes of heat and cold, as well as other mechanical and chemical factors that will contribute to the obstruction of blood flow.